to talk about tonight is a way of thinking about Alzheimer's disease that maybe is a little bit different, but that looks at, first of all, what are the challenges facing us in terms of public health that are going to potentially lead to a great increase in the number of people afflicted with Alzheimer's disease. To talk a little bit about a question that plagues all of us in the field. Why, after so many years of work, are there so few effective treatments? We know we have some treatments that make things better for a little while, but with all the work that we've been putting into this question for the last 20 years, we feel like we should have better treatments to offer you and your loved ones. And part of the reason we think that that may be the case is because of this new way, this new pathway that we think can lead to a greater risk for developing Alzheimer's disease, which is the epidemic of insulin resistance. And I'll explain. That is a hard couple of words for Dr. DeCarli to say, but I will explain a bit about that and why we think that's so important. And that viewing Alzheimer's disease this way offers a new way of developing therapies. So that is what I'll cover in the next 40 minutes or so. I don't have to tell folks in this room, I'm preaching to the choir about how common Alzheimer's disease is. It's the most common form of dementia. Recent estimates saying that about 5 million Americans are afflicted with it, but unfortunately many more expecting to be afflicted with it in the coming years. So up nearly double in the next 15 years or so. And just to talk, those of us in this room who have a loved one with Alzheimer's disease, myself included, know how Alzheimer's disease can affect a person's ability to function. And when we look at the clinical symptoms of Alzheimer's disease, the hallmark, of course, is an impairment of memory. But then other thinking abilities begin to become compromised as well. And unfortunately, again, as we know all too well, these problems progress until there's quite a significant loss of ability. And what is it in the brain that underlies these symptoms? That's one of the things we try hard to understand because we think it will give us insight into how to fix them. So we know that one of the very first things that happens is the brain cells lose the ability to communicate with one another. They then go on to develop a problem with using energy. Just the way your muscles need to use energy, your brain cells need to use energy as well to carry out their functions, and there begins to be a problem with this. And finally, the brain cells are starving in a sense, and they begin to die, and we get a loss of the brain volume, the brain tissue. And then as part of this whole story is inflammation. So we know inflammation causes a lot of diseases. In your knee, it can cause arthritis. When you have a wound that doesn't heal correctly, it can cause pain. Well, inflammation in your brain can cause a number of equally problematic processes that we think contribute to the development of Alzheimer's disease. And you can see here, quite dramatically, I think, here on the left, this is the brain of a person who passed away who was healthy, a healthy older person. And on the right, you can see a brain of a person who passed away from Alzheimer's disease, who was the same age. And I think it's quite clear, you can see how shrunken this brain is, and that's the loss of brain cells that occurs late on in the disease. So when we take that brain and we look at it under the microscope, here is what we see. And we see two types of injury that are associated with Alzheimer's disease. One is called tangles, and that's these dark triangular shaped structures, which are caused by abnormal accumulation of a protein called tau. And the other are called amyloid plaques. They're these spherical structures, and they're caused by abnormal accumulation of another protein called amyloid. And so we know that Alzheimer's disease is a disease of protein accumulation. And this accumulated protein quite literally gunks up the works, if you will, for lack of a better scientific process. It stops the neurons from being able to work well together. Now, I think this last point is probably the most important new piece of information that we've learned in the past 5 years. And that is this damage, these plaques, these tangles, the cell loss, that begins 10 to 15 years before any symptoms are present. So a person can be functioning very normally, but they will have this happening. And I think most of the time when I first learned this and when I tell people about this, they think of this as a scary thing, because here we could all be sitting here feeling fine, but this is happening without our knowledge. And yes, that can take you aback. But I do think it is also one of the most hopeful things we've discovered, because if we can intervene at this point, the person is fine, they're functioning fine, their memory is fine. If we can just intervene at this window of opportunity, then we can keep people stable. And so that, I think, is a very important thing to remember, and this discovery, I think, is one of the most important things that we've learned. This is a long process in developing, and that gives us a lot of opportunity to intervene. So how is it diagnosed? Just quickly, you have experts here at UC Davis that do this as well as anyone in the world. The clinical report of the family is oh so important. I mean, usually the family members know first. And then the interview with the patient is important to detect the specific types of problems that patients have. Then there are formal tests of memory, because it's hard sometimes, especially with a very educated person who is very early. It's hard to really see the memory loss in everyday life. They complain, but yet you're not sure. Is this just aging, or is this a problem with memory? And we have tests that will help us identify problems with memory that are more than can be expected by age. And then there's brain imaging, taking brain scans, pictures of your brain. So there's MRI. And what you can see with MRI is a loss. Again, this is a normal person's MRI. This is a person with Alzheimer's disease. You can see the loss of brain tissue, and this area right here, this is the hippocampus, which is the area that's very important for memory. And you can see a nice plump hippocampus here, and you can see it quite shrunken. And so this is suggestive, but not specific. You can have other problems that will cause this. A little more suggestive is looking at the brain's use of energy. And this is done with a PET scan. And what you're seeing here, the red areas are the brain using energy. So you see much less of those red areas in this person who has what we call mild cognitive impairment, which is a state where there are memory problems, but the person is still functioning pretty well. And then many of these folks will go on to develop frank Alzheimer's disease. And of course you can see large black areas of no or little energy use. So this is highly suggestive. And then more recently, there are even more specific scans, again, available at the top medical centers like UC Davis, where we can image that amyloid protein. We can see the amyloid protein in the brain, and here the red is amyloid protein. So you can see quite a bit of it here and virtually none in the healthy person. And again, we're just learning. This is a very new technology. It's not reimbursed by insurance typically. It's something that researchers are using to try to understand whether this can be a helpful tool for diagnosing Alzheimer's disease. And using all this information, an expert, a group of experts, such as you have here, can be very certain of this diagnosis. They can be as certain as 90 to 95% accurate with this panel of procedures. Now, this is not a blood test, so it's a complicated phenomenon to do this. But again, we can do it if we have all this information. So once a person is unfortunately known to have problems that look like Alzheimer's disease, what are the treatments? And currently, the strategy for treatments is to increase levels of specific chemicals in the brain or to reduce the brain cells overactivity. And unfortunately, these effects are modest, and they typically do not persist over time. The person continues, unfortunately, to gradually get worse. And so again, this is the question that we struggle with. Why can't we find an effective treatment or a cure? And a lot of people have given this thought, and I think the way the field is moving is the first thing, it seems like maybe these treatments are being started too late. As I said, there's already so much damage that happens at the time someone is diagnosed. That damage starts happening 10 to 15 years before. That is when we would need to intervene. So that is one likely possibility. And here is what we think is going on with the progression of Alzheimer's. So here you have cognitive function, thinking abilities, higher is better. And here's what a normal, healthy older person, they stay stable for a very long time, may have a few little dips as they reach late old age. Now, a person that's going down the Alzheimer's pathway begins in this stage we're calling preclinical, and they have already these amyloid plaques. Now, if we can identify people here before they start to go downhill, we have a much better chance of rescuing them. But we need a reliable marker. And as they progress, they go through this mild cognitive impairment stage and on into frank dementia. Now, intervening here during the MCI stage, so the person is having mild memory problems, but they're still home. They're still functional. They can still enjoy their life. And I think that's a worthy goal. If we can find a way to keep somebody stable at that stage, I think that would be a huge accomplishment. And what the statistics tell us is if we can delay the onset of Alzheimer's disease by 5 years, we would reduce the number of cases by half. And those people would have lived a longer period of time in health with a better quality of life. So again, I think this is a really, delaying the onset is a worthy goal in addition to just frankly curing the disease, which of course we'd all like to do. So the other thing that has driven our work is that we believe that the treatments that target Alzheimer's disease focus very narrowly on individual symptoms and individual chemicals in the brain. And Alzheimer's disease is a multi-system disease. And we think that it needs a multi-system intervention. So we can take a lesson from HIV, okay? 20 years ago, HIV/AIDS was a death sentence. Over that time, what people learned was that combinations of therapies to address different parts of HIV pathology became effective. Until now, HIV is just a chronic disease that needs chronic management. And so we believe that we are going to have to do something similar in Alzheimer's. We are going to have to attack multiple causal pathways, either by providing combination therapy or by finding therapies that address multiple pathways. And so that leads me, a little bit of a long preamble, to why we think insulin and insulin resistance are one such pathway. So insulin, you're probably very used to hearing about it with respect to diabetes. You probably know that insulin gets produced by your pancreas. But I think maybe you don't know as much about the role of insulin in the normal brain. And so insulin has a very important role to play in a number of brain functions. Just the way it increases energy use in the body, it promotes uptake of energy in the muscles. It does something similar in key brain regions. Insulin can modulate levels of the brain chemicals that I talked about that seem to be deficient in Alzheimer's disease. It can enhance brain activity, and these are studies that are now carried out really usually in rodent models, in animal models. It can protect against these proteins, these toxic proteins like amyloid. And as maybe is not surprising, given the sum of these actions, it seems to have a beneficial effect on memory. That's the normal situation. What happens when insulin can't function? And that is this condition, Dr. DeCarli, called insulin resistance. So when insulin cannot function, insulin resistance just simply means that cells in the body and the brain don't respond to insulin normally anymore. They need more and more and more insulin to work. So I'm often asked, well, what causes this? What is the cause of this happening? And the causes are remarkably common. So a poor diet, we'll talk a little bit about what we think that means, physical inactivity, being overweight, having chronic stress, okay, all of us living with our loved ones with dementia, chronic stress, sleep disruption, and then there are some genetic vulnerabilities that can contribute. So all of those are extremely common, and I don't know about you, but I've had 4 of those 6 in the last 24 hours. So these are extremely common conditions which, when they persist over time, over months, over years, lead to this metabolic dysregulation that we call insulin resistance. And unfortunately, conditions associated with insulin resistance are increasing dramatically. So the most well-known probably is prediabetes or diabetes. And the latest statistics from the CDC are that 65% of all adults over 60 years of age have either prediabetes or diabetes, and only half of them know it. So this is not just a few people. I mean, this is an extremely prevalent condition. Hypertension. About half of all adults with hypertension have insulin resistance, even if they don't have diabetes. Obesity. 60% of adults over 60 are overweight or obese. And as we have shown, and other very good studies have shown, Alzheimer's disease is also a condition associated with insulin resistance. And estimates are somewhere of a risk increase anywhere between 2 and 5-fold for folks who have type 2 diabetes. So this is a pretty strong link. So many adults, as I've said, with Alzheimer's have insulin resistance in their body, such that as is associated with diabetes or hypertension, and they also seem to have markers of insulin resistance in their brains. And if they have insulin resistance in their brain, then insulin can't carry out all those functions that I told you about, increasing energy use or helping to clear proteins or helping to having the neurons and the brain cells communicate with one another. And we showed a while ago that insulin levels are reduced in the brain system. Here we're looking at spinal fluid, and you can see insulin levels in normal adults are higher than those with early AD, and adults with even more severe AD have even more severe lowering of insulin. So we asked, could treatments that boost insulin help patients with Alzheimer's disease? So we hit upon this approach that we think is novel, which is to administer insulin through the nose, so intranasal insulin. And insulin that's administered this way reaches the brain in 15 minutes, and it doesn't get into the blood. So it doesn't change blood sugar, it doesn't raise insulin levels in the blood. There is a pathway from your nose to your brain that through which molecules like insulin can travel. So and this happens very quickly, and they follow nerves that go through your nasal cavity back to your brain. And there is a pathway that goes to the front of your brain, a pathway that goes to the rear of your brain. And so we wanted to see if we provided insulin directly to the brain in this manner, would we be able to help memory in adults who had Alzheimer's disease? So our promising early results, we had what we called the study of nasal insulin to fight forgetfulness, or SNF. And the first thing that you have to realize is that to have a successful clinical study, you have to have an acronym. You have to really, so we worked hard to come up with this acronym, which we think captures the study well. And this study involved more than 100 adults with early Alzheimer's disease, and they were randomized, so as with a flip of a coin, assigned to either a placebo group that received an inactive substance, which is something we need to do in order to just see what the effects of being in a study are, or to one of two insulin groups, a lower insulin group or a higher insulin group. And we administer insulin with a special device. It looks something like this, but it's specially designed to deliver the insulin to the upper part of the nasal cavity, which is sort of the sweet spot that you need to get it to in order for it to go to the brain. And we gave folks some tests, cognitive tests, before and after they started the treatment with insulin. We also looked at how well they could function on a daily basis. And then we looked at their energy metabolism in the brain, how well their brains could use energy using the PET scan. So here's what we saw. What I'm showing you here is a measure of decline in memory or cognitive function. So higher means the person got worse over time, from the beginning to the end of the study. And you can see the black bar are the placebo group, the group not getting an active treatment, and they showed considerable decline over the trial. But both of the insulin groups were protected against that decline. They, in fact, didn't change at all. Here we have their decline in functional ability, so how well they can carry out their daily activities. Again, a higher score is a worse score. So the placebo group declining, and the two insulin groups stabilized, and in fact the higher dose showing no decline over the study period. And then finally, we looked at the brain energy metabolism. So what you're seeing here, the hot spots that are bright yellow and orange are areas where there was a decline in energy use over time. So the brain is using less energy. And you can see that the placebo group showed several areas of quite significant decline, and none of the areas for either of the insulin groups were significant. They did not show any change in energy use, and in fact, improvement in some areas. So these were very promising results, but of course, this is only one trial. So the next steps, this large trial has begun at 30 sites across the country, and if successful, this would provide the basis to seek FDA approval for this as a new treatment. And this trial will be happening at this center, so that is something that's available to folks here in this community. So next steps, where are we taking this work? Well, as I said, we think we need to get as early as possible in this process. So we're looking at interventions that could potentially prevent symptoms before they occur. And so I want to show you here, this is, up here is a pattern of brain energy use in patients who have Alzheimer's disease. Again, low, the hot spots are low. Below that is the pattern of brain energy use in normal adults who have insulin resistance. And you can see they look almost identical. So we think that this brain signature of Alzheimer's disease shows that there are problems with brain energy long before there are cognitive or thinking problems in patients with insulin resistance. So we want to find ways to intervene to prevent Alzheimer's disease, either through drug therapy or through lifestyle intervention, and in particular through diet and exercise. So I told you that the most common causes of insulin resistance are diet and inactivity, and that the prevalence of these conditions is greatly increasing, partly, we believe, due to changes in physical activity levels and this Western diet, which is characterized by saturated fat and sugar, as opposed to the healthier Mediterranean diet, which is characterized by lean protein and fruits and vegetables, such that if Mona Lisa were to move from the Mediterranean and come to live here in the US and get a desk job, unfortunately, this might happen. And what we've discovered, many of us in the field have now learned that it is your patterns in midlife that are very important. This is when many of the processes are being laid down. That doesn't mean you can't improve your situation in older age as well, but we know that things are starting in midlife, and this is really the point at which we could best and most effectively intervene to prevent problems. So here's a little information from the National Nutritional Council on the change in our diet with respect to sugar consumption since, let's just look at even, go to 1960. And what you can see is we are currently consuming over 100 pounds of sugar a year per person. So that's 2 pounds a week. That's like you sitting with a 2-pound jar of sugar and a spoon and eating that every single week. And the reason is because it's hidden in so many places in our prepared food. It's called corn syrup. It's called various names, dextrose. But the truth is, it's sugar, and it has the same physiological impact on your body. Now, also, we're consuming many more calories a day. So just again, since 1970, we've increased the amount of calories we're taking in per day, 400 calories. That's like 25% more than a normal person would typically consume. So these are striking dietary changes, and that is what's happening, now. The trend seems to just be going higher and higher. So one of the ways you can reduce Alzheimer's risk is, in part, studies have shown that reducing your calorie intake can slow aging, and some of the most interesting studies were carried out in animals. So here's a study carried out at the University of Wisconsin. These are monkeys. On the left is a monkey that was fed the Western diet. On the right, the same aged monkey fed a reduced calorie diet, 20% reduction in calories from midlife on. And I think you can see the difference. You don't need a statistical test. So the men's hair loss industry is very worried about these results. Pepper. So what we know is that, and of these animals, 80% of them developed prediabetes or diabetes, and of these animals, none did. So reducing your calories by that much is a pretty daunting task. So we wanted to know, can we just make your diet more healthy or less healthy? And can we see effects on processes we know are related to Alzheimer's disease? So folks came to our clinic and volunteered to be in a study in which for 1 month they were on what we're calling a bad diet, which is high saturated fat and high sugar, and compared that with another group of folks who went on a good diet, low saturated fat. And let me emphasize, low saturated fat. We know that healthy fats are very important, but saturated fats are a different story. And we looked at measures of amyloid, that toxic protein, and inflammation in their spinal fluid. And we look at spinal fluid because it's as close as we can get to the brain. The spinal fluid bathes your brain, and many of the chemicals that are contained in the spinal fluid directly reflect chemical processes going on in the brain. So here's, and I'm also often asked, how could you put people on a bad diet for 1 month? How could you do that? And I would say to all of you, this is the diet between Thanksgiving and New Year's. This is the diet we're all on. So this period is not something that does not have a real life analog. So here's what we saw. What you're seeing here is change in this amyloid protein, this toxic protein on the left, in spinal fluid, such that a higher value means it went up over the month, and a lower value means it went down. And so the high fat, high sugar diet, those levels went quite a bit higher. And the good diet, they went significantly lower. And when we looked at our markers of inflammation, they mirrored this perfectly. So higher inflammation with this bad diet and lower with the good diet. So 1 month of eating this way, and we didn't change calories. Nobody lost or gained weight. It was identical calories. We were just changing the quality of the diet and what the people ate. So 1 month of this diet could expose your brain to higher levels of amyloid and higher levels of inflammation. So let's talk about the other part of the equation, which is exercise. I took this photograph of Dr. DeCarli, and unfortunately, it's all too common, the ways that we have, the lengths that we have gone to reduce our physical activity levels. So here's, again, recent trends. This is the change in the amount of activity you get as part of your job. All right, so if you look at these figures, the numbers are hard to read, even up here. If you look at these figures from 1960 as the starting point, the precipitous decline in the amount of activity you get as part of your work. And for me, my activity at my job consists of this for about 8 to 9 hours a day. It is just stunning how little physical activity I get as part of my work. And then below this, it's equal for men and for women. So the equal decline. Women get much less than men do overall in terms of their occupation. So you're thinking, well, maybe this means that people are doing a lot more physical activity when they're outside of their job. Maybe they're mountain biking or climbing rock cliffs or something along those lines. But in fact, the situation is exactly the same. So this is really hard to read, but I will tell you that the bars represent the number of people who say they do no physical activity in their leisure time. And they're broken down into categories like Hispanic females, non-Hispanic white males. So the point of this is every single category of every single ethnic, gender, and demographic section of society now has an amazingly high number of people who say they do no physical activity as part of their leisure time. And why is that? Because this is the physical activity that everybody is doing, or even kids, video games. So you combine this dietary change with this physical activity change, and it's just not a surprise that we're having the kinds of issues. Exercise is one of the most potent, beneficial anti-aging things you can do. In animal studies, exercise has positive effects on brain structure, increases brain volume, increases blood flow, increases resilience to Alzheimer's. And in clinical studies now, careful clinical studies are building support for exercising having a positive effect on memory and other thinking abilities in older adults and in adults with mild memory impairment. So here's a study from the University of Illinois in normal, healthy older adults in which 6 months of aerobic exercise resulted in increased brain volume. So remember I showed you how the Alzheimer's brains were shrunken. Well, here, what you can see in blue are areas of the brain where the brain actually increased in volume. In blue and in yellow, the white matter that connects the brain cells actually increased in volume. So that's a pretty striking anti-aging effect. And in recent work, we showed that, Laura Baker from our group showed that in adults who are at risk for Alzheimer's disease, dementia, because they have mild cognitive impairment and prediabetes, blood flow increased in key brain regions after 6 months of aerobic exercise compared to stretching. So currently, there is now a multi-site study, a clinical study being planned in the spring that will happen at a number of centers across the country in which 300 adults who have mild cognitive impairment will be enrolled in a year-long exercise trial. And this trial, were it to be successful, would result in exercise being able to be a prescription. You would be able to go to your physician if you had a mild memory problem, and he or she would be able to prescribe exercise for you. And you say, well, that sounds silly, but it's not, because then that leads the way for the cost of health club memberships and supporting paraphernalia not Nike high tops probably, but costs related to exercising could then be covered by your insurance. So let's talk finally about intervening with medications. And I just want to tell you about a trial that's starting, that's also happening here, in which the goal is to find people who are still thinking normally and still have normal cognition, but they have amyloid in their brains. We can see it with these scans that I showed you. And those folks will receive a medication that works against amyloid. So this is called the A4 study. It's a very large study. It will involve 1,000 normal older adults from age 65 to 85 who have this evidence of amyloid. And it will require quite a commitment that these folks will commit to taking this medication that attacks amyloid or a placebo, equally likely to get a placebo, for up to 3 years to see if this helps preserve their thinking abilities. And again, something that's happening here at Davis. So let me just sum up. Insulin resistance and all of the conditions that go with it, the prediabetes, the diabetes, the hypertension, all of those greatly increase, we believe, your risk of changing with aging and having your cognitive abilities become more compromised with aging, as well as increasing your risk of developing Alzheimer's disease and other forms of dementia. And without being alarmist, it does give one pause to think about how the prevalence of these conditions are increasing so dramatically, in large part likely due to these unprecedented changes in the way we eat, the way we move or don't move. So the convergence of that trend with the trend of our population getting older. We have many more folks now in that older demographic who are going to be susceptible to these influences. So this, I think, does give one pause. However, we think that this is ultimately a hopeful message because we can identify the root causes of these conditions, of this insulin resistance, of the conditions associated with it. We can identify them. We know how to address them in many cases. And so we think that working on this target area will lead us to new interventions that will help us prevent or delay or treat folks with Alzheimer's disease.
Okay, I have technically two questions. One is, if you're a diabetic, do you have insulin resistance? Because a long time ago, I used to have my insulin checked, and it was always high, and my glucose was always low, or in the normal range, but then when my insulin went into the normal range, then my glucose went up, and now I'm a diabetic. So I'm kind of, if I'm a diabetic, do I still have insulin resistance? And the second question has to do with sodas. We probably shouldn't drink any sodas, but I'm thinking diet sodas, even though it has low calories, it kind of fakes out your pancreas and thinks you're drinking sugar and raises up your glucose as well?
Yeah, thanks. Those are great questions. If you do have adult onset diabetes, you almost certainly have insulin resistance. Even when your insulin levels start to go down, they don't ever go down to normal. And usually the medications that you're using to treat them will keep them elevated. The way insulin works in a non-diabetic person is you have a spike and then it goes down to nothing after you eat. So even folks with type 2 diabetes who eat a meal will have prolonged insulin excursions. So it's always, that's why it's so important and you and I talked a little bit before, it's so important to take good care of yourself and to do the physical activity, because that way you can really have a beneficial effect on that insulin resistance. So this idea, I mean, everybody would agree, I think, that a big gulp of regular soda is not a good thing. But there's a lot of controversy about the sugar substitutes now, because we know that your brain can perceive sweetness and think it should be getting calories, and then when it doesn't, odd things may occur. So I think the jury is still out about that, but I think the mainstream opinion would be to use caution. I mean, not to have 6 packs and 6 packs of diet soda every day. To minimize the foods that are super sweet. To get your sweet fix through fruit. You know, the best, not fruit juice, but fruit, things that have fiber. That would be, I think, what the mainstream would say.
Well, I had a question, but I can't remember. You know, when you showed the brains, when you showed the brains, and I think it was the insulin resistance, I wondered how far along these people were. Was it the normal brain, or was it mild cognitive impairment, or what?
No, they were cognitively completely normal. We carried out extensive testing on them. So as with other types of risk factors for Alzheimer's disease, you can see this signature while people are still completely normal. That's a great question. Yes, sir.
On insulin resistance and treatment, what is being done by the medical profession to try to increase people's ability to use and build up their insulin rather than resisting it?
Well, I do think that the medical community is trying to move more towards a public health and prevention stand, in which they are talking about exercise, they are talking about diet, and exercise is the most potent intervention you can have for insulin resistance. That being said, I do think that there is a tendency to fall back on medications. There's a opinion that you'll never be able to get people to exercise. I've heard that opinion espoused over and over again, so they need a pill. And so I think that's not giving us enough credit. I think I'd like to look at the public health campaign in France about smoking, and they have decreased smoking by 2/3. I mean, those of you who love France, I love France, to think that the French would now not be smoking and that you can go into most restaurants there and they're smoke-free is almost unthinkable. I think we could have the same kind of public health campaign that would get people more in on the line of exercising and eating right, and the medical community could help that.
I have a question about dementia versus Alzheimer's. My mother died, they said Alzheimer's. Then her doctor said, you know, I don't really think it was Alzheimer's. I think it was dementia because of the little strokes she might have been having. So I understood that you can't tell if it's Alzheimer's unless you do an autopsy.
So that's a great question that brings out a lot of the more subtle issues. First of all, dementia is a general term, and Alzheimer's is a type of dementia. And then there's other causes of dementia that are not Alzheimer's but relate to strokes. So, but the truth of the matter, now that we have had large number of people donate their brains to science, we see that the norm is for people to have both things going on once they reach a certain age. So if in a person who dies with Alzheimer's in their 80s, something on the order of 3/4 of them will also have some stroke-like events, and probably the dementia is caused by both. It's probably caused by the impact of the stroke and the impact of the Alzheimer's together.